Good evening, respected teachers and colleagues. Today I'll be presenting a case of a 43-year-old male who is a railway employee by occupation with no prior comorbidities. He first came to our follow-up in 2018, where he first presented with bilateral symmetrical proximal muscle weakness, both upper and lower limbs, with periorbital edema, inflammatory polyarthritis, Raynaud's phenomenon, and extensive calcinosis. I'll be predating the history to when he first presented to us, as there is historical significance to it. And so he first came in 2018. Eventually, in 2019, he was on treatment, that is methotrexate 25 mg per week and azathioprine in view of myositis with extensive calcinosis from our institute. And despite of which, the patient continued to have persistent weakness and calcinosis with inability to taper steroids below 10 mg. So in 2020, he started developing bilateral mechanical hip pain, at which point we did imaging, and he was found to have bilateral hip avascular necrosis. Eventually, due to the persistent weakness, the calcinosis, and steroid-related complications such as the hip AVN, he stopped all medication and shifted to alternative medication. That is in 2021, and he was lost to follow up for the last 3 years. So, in December 2023, he presented to us after being lost to follow up for 3 years with worsening of proximal muscle weakness associated with progressive dyspnea on exertion and painful ulcers on right flank and buttock. These symptoms had been worsening for the last 6 months. And on examination, there was significant neck flexor and truncal weakness. Although there was no bulbar involvement, gag reflex was present. And on respiratory system examination, basal and inspiratory crept and diminished workings were there.
I want everybody to please mute yourself other than the presenter.
So these are the examination findings of the patient. He presented with the following. He had significant vasculopathy. So he had digital ulcers, as you can see in the third picture. And he had significant calcinosis in the gluteal region, as is evident on the X-ray. And on MRI, there was T2 hyperintensity that was present in bilateral gluteal and thigh muscles. So workup was done. He was found to initially, while he was in our follow-up in from 2018, MSA panel was not done for the patient. So when we started workup, we found that hemoglobin was 8 grams on the lower side. Total leukocyte count was 10,000 with mild lymphopenia. Platelets were 1.5 lakhs. SGOT was more than SGPT. ESR CRP were raised. Ferritin was 491 initially. CPK 69, LDH was raised. And MSA done was suggestive of MDA5, that was 2 positive. And as you can see in the chest X-ray, there are bilateral basal infiltrates in bilateral lower zone, and bilateral pleural effusion is evident. So pleural fluid analysis was done, which came out to be exudative, and it was negative for infection and malignant cells. So here the baseline CT was done, where you can see that bilateral basal predominantly multiple consolidatory patches are seen with bilateral moderate pleural effusion and pericardial effusion. So basically we diagnosed the patient as to have ILD with NSIP and OP pattern. So here in the course of treatment, we started the patient on 1 mg per kg steroids, and initially the symptoms started improving. That is, the muscle weakness started improving, and he had subjective improvement in dyspnea. And he was hence planned for rituximab 1 gram induction in view of refractory myositis with chronic steroid dependence and new onset ILD. The ILD was not present at onset in 2018. So during the course of hospitalization, within 1 hour of rituximab infusion, he developed atrial fibrillation, which was managed with calcium channel blockers, diltiazem, and eventually the rate settled. Within 24 hours of the first induction dose, he developed worsening of the dyspnea with dry cough, and he started desaturating with SpO2 going below 88%. So here we can see that this is the initial chest X-ray which we saw just now, and this is the new chest X-ray which was done 24 hours after Ritux infusion, where you can see that there is a new patch of consolidation in the left middle lobe. So at this point of time, we managed the patient symptomatically with oxygen and started the patient on broad spectrum IV antibiotics. We started the patient on meropenem and linezolid, presuming that it could be infective. And we did a CT scan of the patient. So this is the CT scan
1 minute left.
Pre-rituximab, where you can see that there are those infiltrates, and here you can see that post-rituximab there is increase in the infiltrates in the basal region and the left middle lobe. So here the possibilities we considered for AF and organizing pneumonia. AF could be possibly related to the infusion reaction, and the organizing pneumonia we thought could be drug induced in this case, maybe due to the rituximab infusion. But our dilemma was to rule out infection and disease activity, for which BAL was done. There was no evidence of infection and cultures were sterile. Procalcitonin was normal. Even cardiac biomarkers were normal and ejection fraction was normal. SARI panel was negative. Further, in the course of events, the patient was continued with the rest of the infusion and discharged on 1 mg per kg steroids. And later, the second dose of induction for IV rituximab was also given, which was uneventful. And
Thanks, sir.
during the 6 month follow up, the patient had improvement in dyspnea and components of MMT8. And in June 2024, he was admitted for first maintenance dose of rituximab after 6 months. Within 3 hours of the infusion, he developed again sudden worsening of dyspnea with high grade fever and was admitted on day 7 post rituximab infusion and again found to have desaturation. He was again managed with oxygen and empirical IV antibiotics. At this time, the steroids initially were less than 7.5. Now we increased the steroid dose to around 0.25 mg per kg IV hydrocort equivalent. And the CT thorax and BAL were again planned. Again, same dilemma if it was infection, disease activity, or due to the infusion per se. So pre-rituximab, as you can see that the ESR and CRP inflammatory markers were normal and rest of the investigations also normal. And post-rituximab, here we can see that the ESR and CRP had increased. These investigations are 1 week apart. And again, workup for cardiac cause or myocarditis, workup for infection came out to be negative. That is negative procal, negative viral panel, negative for CMV PCR. This is the CT which was done in June post rituximab. Here we can see that there are new patches of consolidation in the right side as well, in the right upper lobe and middle lobe. And some of the patches had started resolving. So what happened now exactly? We were thinking that this could be drug-induced pneumonitis since there is a temporal relation to it. The first episode manifested within 24 hours and the second episode manifested within 3 days of infusion. And both of them required hospitalization. Infection was definitely a possibility, but in this second episode, RP-ILD for disease activity, there were definitely oddities because the patient had well-controlled disease on immunosuppression. So here we did a bronchoalveolar lavage again. Here we found out that there were more than 70% neutrophils with a TLC of 3,850. And in gram stain, there were few gram-negative bacilli, and culture was sensitive to was suggestive of pseudomonas, which was scanty growth, but it was resistant to our antibiotics. And workup for fungal and CVNAT for MTB done was also negative. So here the patient improved symptomatically despite of the antibiotics, and he improved symptomatically on steroid, and he went off oxygen within 1 week of admission. So the dilemma here is what to label the patient as. Our first possibility was that the rapidity of the onset was within few days. So we thought first that it could be rituximab-induced pneumonitis, over-infection, or disease activity, definitely in the second case. And even for infection, there was a scanty growth of Pseudomonas, which was not like we could not explain the clinical improvement with the resistant antibiotics, and the radiographic features were also definitely odd. And even if we exclude the possibility that it was infective or drug induced, what should we do for the subsequent immunosuppression?